Chairman, ladies and gentlemen. Thank you very much. First of all, I would like to say that I'm very proud to be a member of this faculty and as the co-organizer of this meeting together with Jean-Louis and Maurizio. I'm very happy that such a great faculty accepted our invitation to come and speak here. I'm going to speak about cardiac output. These are my conflicts of interest. Most important, I'm a deputy of the CD section of this society. And I would like to talk to you in the next minutes about cardiac output measurements, invasive or not invasive. So there are lots of techniques on the market, as you might all know. And first of all, I would like to go through them. Not every one of you might be familiar with them. And then we put it all together and see which one you use. Let's start with the more invasive ones, the thermodilution methods. You have the pulmonary thermodilution method. For that you need a Swan-Ganz catheter like this one, or you have a transpulmonary thermodilution where you measure your output signal in the aorta or in the big artery, and this is the transpulmonary one. Both techniques have the same principle, so you inject in a central venous line a cold fluid bolus, and you measure with the thermodilution technique with the PA catheter at the tip of the catheter, and you get a signal like this. Or with the transpulmonary technique, you get a, it's not working. You measure at this point in the big artery, and you get a signal like this. So it's a little bit damped. It's over. You don't see the respiratory respirations, but the area of the curve is representative of the cardiac output, and this is the same for both methods. And you can calculate the cardiac output by dividing the mass, so the amount of cold you injected by the area under the curve. And this way you can calculate cardiac output. This is the Stewart-Hamilton principle, which has been referred to earlier. And this measurement is still considered as the gold standard for cardiac output measurements. You usually do 3 to 5 measurements, you average these, and it has some limitations. Of course, it is invasive, as we said, and this may cause some complications. There is some lack of evidence, maybe, to the usefulness of these. We'll come back to that in a minute. So in our institution, for example, unfortunately, it is not very common to put in a Swan-Ganz catheter, and we have only very restrictive indications like listed here, where we still use it, but not for, let's say, a standard cardiac case. A variation of this technique is the continuous cardiac output monitoring with a pseudo-randomized thermosignal. So what does this technique? They have a thermofilament in this pulmonary arterial catheter, which is in the right ventricle, and which randomly gives a thermosignal, like here, an input signal, and this is measured at the output side. And so it's not cold injection like the previous method, but now it's warm, but it gives you the same kind of information. And is this continuous? Is this real time, or is it accurate? This has been challenged some years ago. So this is a model study where they, in a closed loop system, they could very nicely change the temperature, and they measured with 2 of these catheters from 2 different companies, and these are the results. So you see they do follow the temperature changes the flow changes quite well, but with a delay. The delay here was 9 to 50 minutes, and there was quite an offset. So one catheter overestimated the real cardiac output by 2 liters, and the other one underestimated it by 2 liters. So the conclusion of that paper was it's not real time, it's not continuous, and it's not very accurate. And this is maybe one of the reasons why the use of pulmonary artery catheters has declined over the last years quite dramatically, although the companies selling these devices deny this. But these are the numbers just published recently. And it started all with this study in the ICU, almost 6,000 patients, where they matched patients having no right heart catheterization and right heart catheterization, so a Swan-Ganz catheter. And the mortality was higher in the group that had a Swan-Ganz catheter, there were also higher costs and prolonged ICU length of stay. The study was discussed, of course, and criticized because, of course, patients may be needing a Swan-Ganz catheter, maybe the sicker ones, and there have been a lot of studies, I won't go through these, which challenged this concept and even looked at concepts using information from the Swan-Ganz to improve the patient, but the conclusion was, from all of these studies, there's not a benefit from a management based on pulmonary artery catheter. And also the recommendations from this group of experts, some of them are here at this meeting, say we do not recommend the routine use of the PA catheter for patients in shock with a level A1 evidence and a high quality of evidence. So the question is the Swan dead? Because it does not improve outcome, it provides misleading data. We didn't talk about that. The physicians and the nurses do not understand many of these measurements which are derived from the catheter, and it might be not that accurate as we think. But still, this is a survey from Switzerland some years ago, and they asked their intensivists, what do you use? And these are the results. So still, a third of them uses the pulmonary artery catheter for monitoring, hemodynamic monitoring in their ICU. And the other big group was transpulmonary thermodilution, which we will talk in a minute. And in this hemodynamic monitoring concept paper we published last year with a group of experts, we still have we still find a place for the pulmonary artery catheter, as you can see in this decision tree. So the next technique we can talk about is this one, the transpulmonary thermodilution. We briefly talked about it. There are several devices where you can use these techniques. I already discussed this principle of determining cardiac output, transpulmonary way, but it also gives you a lot of other information besides cardiac output. We will not talk about this today because this lesson is on cardiac output, but you can also, just to mention it, get information about the global end-diastolic volume, so a preload indicator about lung water, edema formation, about the capillary leakage, about systolic cardiac function, and about fluid responsiveness from these methods. So it provides you a rather full hemodynamic assessment. So again, in this recommendation paper, we gave it a very prominent place here in these patients which are quite sick. What is the reality? How many times are they used? Or with that, we come to the next step of cardiac output monitoring, which are based on the pulse contour analysis or arterial waveform analysis. Based on that, what the previous speaker said, you can not only derive information from pressure, but also cardiac output from the arterial pressure signal. And these methods are used quite not so often, but around 10% in the OR or in the emergency department are equipped with that. And these are the technologies we will go through very briefly in the following minutes, which are based on these devices. Let's start with the FloTrac device. So again, all of these devices are based on the arterial pressure signal, which you can derive from any of your arteries, and this pressure signal is converted in cardiac output information by some kind of pulse contour analysis, and every company has its own appropriate algorithm to do this. Some of them are public and some of them are not. Let's start, as I said, with the FloTrac Vigileo or EV1000 device, which is the oldest one, is on the market for 10 years. And it works, as I said, you can connect it to any arterial line. This is the sensor, which then is then connected either to the FloTrac or to the EV1000 monitor, and it converts the pressure signal into information or flow. How does it do this? So it collects the arterial pressure signal for 20 seconds, then it measures the standard deviation of this pressure signal, and by deriving this information and multiplying it with heart rate and a number of patient factors, it can calculate the cardiac output. There have been, it has been on the market for 10 years, as I said, and there have been a lot of software versions out there and revisions up to the third generation. This is summarized in this analysis, and you see that the if we only look at the percentage error here on the right, it's quite variable from 13%, which is quite good, up to 67% here. The margin which is considered acceptable is 30%, so if your percentage error is below 30%, a method is considered acceptable. If it's above 30%, sorry, it's considered not so accurate. So it's quite variable, and in the meantime, we have a fourth generation software, and these are studies looking at this fourth generation software, but still they come to the conclusion that the first generation is not, if you compare it to the gold standard thermodilution or echo, 3D echo measurements of cardiac output, it's not quite accurate. So it did greatly improve with the previous software compared to the previous software versions, but still not acceptable. The next technique we want to look at is the ProAQT PulsioFlex method. It's quite similar, based on the, so you connect it to the arterial line, and it derives the area under the arterial pressure curve, multiplies it with heart rate and some factors, and you can get the cardiac output. And there have been some studies, again from Jean-Louis' group, showing that this, comparing it either with Swan-Ganz, so thermodilution or transpulmonary thermodilution with the PICO, the conclusion is it did not reliably estimate the absolute values of cardiac index, but if you want to track changes in cardiac output, for example, those after you give half a liter of fluid and you want to see did your cardiac index increase or not, these changes were tracked quite well with this device, and this is maybe as important an information as the absolute value of cardiac output. This is a meta-analysis published some years ago, looking at the accuracy of all the studies published so far based on the pulse contour analysis, and the percentage error was 41% on average. As I said, 30% is considered acceptable, so it's above this measured this limit. And this is a paper we just published, also summarizing these studies. And as you can see here, they have the advantages of not needing an external calibration, which might also be a disadvantage. They only require an arterial catheter, and this is a personal subjective evaluation. We gave it 3 out of 5 stars. With that, I come to the next method, the Doppler method, quite popular in the UK. It's working on like a transesophageal echo that you might be aware of. You put a probe into the esophagus, but now you don't look at the heart. You look at the other side, at the descending aorta, and you get flow signals like this one. And with the same principle, as you know from echo, the VTI times the square cross-sectional area, you can calculate stroke volume in the descending aorta, and then you can recalculate the cardiac output, assuming a constant relation between the vessels from the upper part of the body. From this meta-analysis, again, percentage error was 42%, so similar to these techniques we just discussed previously, and not acceptable compared to accuracy with absolute measurements. And these are the results from our review we just published. The esophageal is quite popular, but the accuracy might be not sufficient for the ICU, and especially in patients who are not sedated very deeply, these probes are not tolerated very well. With that, we come to the completely non-invasive techniques, which are also based on pulse contour analysis, and there are a number of these techniques out there. Again, they use the arterial pressure signal, but now they don't derive this signal directly from the artery, but they measure the arterial signal differently, and we will discuss those. One technique which I worked a lot with is the NextFin technology, which was invented by a Dutch company, and we published how it works in this article. Briefly, we have a cuff around the finger, and this cuff, there's an electrode which looks at the artery of your finger, and it keeps the diameter of this artery constant by releasing or changing the pressure in the cuff. So every time blood stroke volume comes into your finger and the pressure rises, it will decrease the pressure, and by this way it can derive the pressure signal from the finger non-invasively. This principle is based on the Czech physiologist Peňáz, which described this already in 1967. And from this pressure signal, then again, you can, by applying this algorithm, derive cardiac output information from the pressure signal, as with the previous techniques, by applying it with heart rate. This company does no longer exist. It has been bought by Edwards Life Sciences, and it's now called the ClearSight, which is technology which is also connected to the EV1000, which I showed you before for the FloTrac. So this technique is now called ClearSight, but the technique is identical. So the results I showed you with the NextFin will also apply to this technique. This is a summary of all the studies which have been done with the NextFin or the ClearSight in the recent years, and you can see again here, if we only look at the percentage error, it ranges from 29% to more than 50%, again in the same range. And the conclusion from this group was it provides a reasonable estimate of cardiac output. We will discuss in the end what this means. And this is a screenshot I took from my monitor when I used one of these techniques. So this is the arterial line, and this is the non-invasive derived line. You will see that the information you get is quite similar. The shape of the curve is quite similar. There's a small delay, which is, by the way, not caused by the difference between here and here, but by the signal processing. So you pretty much get the same information. Another technology is the CNAP technology, which is based on a very similar principle as shown here. And there are some studies from Bernd Saugel's group, who's sitting here in the front row. He compared it in this study to the PICO, to the transpulmonary thermal dilution, and they could show that if you calibrate, so it was again above 40% if you do not calibrate the CNAP, but if you calibrate it to the first measurements of your transpulmonary thermal dilution, then you can improve the accuracy dramatically. So then you get a percentage error of 25%, which is below the 30% limit, and indicates an acceptable agreement with the PICO. And this is a recently published study from the same group comparing it to the Swan-Ganz, so the pulmonary artery catheter, the gold standard measurements, and they did a passive leg raising maneuver. And again, the percentage error in the beginning was 49%, but it decreased when it was calibrated to the first measurements to 19%, which is very good. And these are is a correlation between the two methods after calibration. And this is the 4-quadrant plot. So if you look at the changes, as I told you, the concordance rate was 100%. So all the changes that you could measure with the Swan-Ganz, if you do an intervention like the passive leg raising in this case, you could find with the non-invasive method the same. The next technique I want to talk to you is the applanation tonometry method, as shown here. It's like measuring the pulse, but by a device. It's like it compresses the artery against the bone, and by this it feels the arterial pressure, and it reconstructs the arterial pressure waveform. Again, the group of Bernd Saugel has done a lot of research on this. These are patients after cardiac surgery, and again, it was compared to the Swan-Ganz gold standard cardiac output, and there was quite a good accuracy percentage error 34% and a concordance rate of 95% if you look at the changes in cardiac output. So it has an reasonable accuracy and precision and is reliably able to track changes in cardiac output, was the conclusion of this group. And this is a recently published meta-analysis summarizing these non-invasive pulse contour analysis methods, and you can see here the range and the percentage error averaging all these methods was again 55%, and these are the recommendations from our paper. So it's as accurate or as inaccurate, if you will, as the more invasive methods like the FloTrac or the ProAQT or the LITCO or the MOSCARE, which I didn't talk about. With that, we come briefly to two techniques which are maybe not so familiar with you: the CO2 rebreathing method, which is applying the Fick principle. So you introduce an additional part into your breathing circuit, and by the decrease the dilution of the CO2, you can measure the cardiac output by this formula. We won't go into detail. Looking at the studies that have used these, again, the percentage error was 44.5%. And this is from the recently published meta-analysis summarizing all these studies, percentage error 40%. So you will find these for all these techniques. And this is the recommendation from our paper, not so accurate as the previously described one. The bioimpedance and bioreactance methods, maybe you heard about, they are also very non-invasive. They just use electrodes attached to the body surface, and they measure the impedance of the thorax, which is the resistance to flow, and changes by the output of the heart into the aorta are measured using a high-frequency current where they can derive stroke volume. There's a modification of this technique which implemented the electrodes into the tracheal tube, as you will see here. So it's closer to the heart or to the aorta, or where you can measure the flow. And all of these studies just come to the conclusion it did not adequately agree with thermodilution measurements of cardiac output. A variation of this technique is the bioreactance, which uses a phase shift of the... sorry? Was there a comment? And these are the studies looking at these techniques. They find a better accuracy of this method. But again, in the meta-analysis summarizing these, you find again the same degree of percentage error, 40 to 43% in this case. And this is from the other meta-analysis, also 42% for these bioimpedance, bioreactance technologies. And these are the recommendations from our paper. So not very useful maybe in the ICU. The last technique is the pulse wave transit time. It just uses the distance from the R wave of the ECG to the moment when the signal is arriving in the periphery. You could measure this by the arterial wave, or even non-invasively with a pulse oximeter. And there's an inverse correlation between the time this takes and the stroke volume. So the higher the stroke volume, the shorter the time. And these are all the studies using this pulse wave transit time, and they have a quite high percentage error of 62%, which is certainly not acceptable, and these are the recommendations. This is when you look at all of these technologies, summarizing at non-invasive technologies, the percentage error was 47%. So they are not interchangeable with the gold standard of bolus thermodilution, and this is the summary from our paper. So if we put this all together in the picture, the question was, is less invasiveness accompanied with less accuracy? And yes, as we wrote in this editorial, indeed this seems to imply less invasiveness, seems to imply less accuracy, but the trending abilities of most of these techniques are acceptable. The trend is your friend. In the perioperative setting, so the pulse contour analysis-based monitoring can be indicated to apply goal-directed therapy. That's where we use it for. And the question is always the balance between accuracy And invasiveness, the more invasive and the higher the risk of your patient, the more invasive should your method be, as in this method. And as always, you should choose the right monitoring for your right patient, as you would not go to the farm with these kind of shoes. And you would not choose boots for going to the opera. This is what this editorial says. So choose the right monitoring for the right patient, and remember, as shown in this editorial, if you choose for one monitoring, this does not mean yet that you always have to stick to that kind of monitoring. You can always change, of course, upgrade your monitoring if the patient deteriorates, or downgrade if the patient improves, which is nicely shown in this figure. And this is again the summary from our expert paper. Non-invasive hemodynamic monitors are currently not recommended for use in patients with shock, since these patients have an arterial line anyway, but they may be used in high-risk surgical patients, and with future developments of these techniques, they will probably become the monitoring of the future. And this is the future. Maybe we have now very small, this is a chip placed on the radial artery, which gives you the same information, and wearable sensors like this one, which can transmit the information to your iWatch or your iPhone. And this will be the future, talking that we can even monitor our patients maybe on the normal ward, where we normally don't have these kind of information available. So with that, I come to my take-home messages. I showed you that transpulmonary thermodilution is the gold standard for cardiac output measurements, and that it can provide you with additional variables that allow you a complete hemodynamic assessment. So for the patient in shock, you should still stick to those methods. Then the methods based on the pulse contour analysis, you have calibrated or auto-calibrated or non-calibrated systems, which are minimally invasive, so you just connect them to your arterial line, or even non-invasive, and they have acceptable accuracy, precision, but good trending ability, so they can track changes in cardiac output much more easily. They give you additional information, beat to beat, about blood pressure, cardiac output, stroke volume, and pulse pressure variation. They have some limitations, as mentioned here. They are useful in the OR, for example, during goal-directed fluid therapy, but maybe less suitable in the ICU. And the other non-invasive systems have very limited accuracy, precision, and trending abilities, so it's too early to recommend them for use outside of clinical studies at the moment. And my last, so the question I was starting in the beginning, from invasive to non-invasive, I would put it this way: it's not a continuous one, so these are very accurate and invasive, and then there's a big step to these technologies, and the step between them and the non-invasive one is rather small, so you can choose them interchangeably, but not with that kind of techniques. And the last slide I would like to present is this one. Everyone knows this picture, right? Who's that? Mona Lisa, very good. Let's say this is the cardiac output, gold standard cardiac output derived from the Swan Ganz, right? Now I show you another picture. What is this? It's still Mona Lisa, right? You agree? Although not a single picture of this, and not a single picture, pixel of this picture resembles one in this one. So it's not accurate, but you still get a picture from your patients. You still get information on your cardiac output. Let's say this is the FloTrac, and this is a bioimpedance thing. You still see it's Mona Lisa, and this is from Roy Lichtenstein. So this is Eddie Warhol, by the way. And so what I wanted to say with that, it's in my opinion, it's better to measure cardiac output at all to get some information, additional information, rather than only sticking to blood pressure measurements. And with that, I thank you very much, and I would like to invite you to come to Vienna to hear more about hemodynamics. Thank you very much.